The final of our Pallium India course. Thank you very much for joining us. Today we have an eminent faculty to lead the last session, Professor Reena George. He's head of department of continuing medical education at CMC Vellore. She was a consultant radiation oncologist in CMC Vellore for 10 years. And in 2004, she started the palliative care unit at CMC, and she has served as the head of the unit till 2019. She's also the former chief editor of the Indian Journal of Palliative Care. So without further delay, I'll hand over the mic to you, ma'am.
Thank you, Dr. Ashok, and thank you, sir, for inviting me and for accepting my request to be present for the session today. Let me just begin by sharing my slides. For some reason, I'm not going on to slideshow. I had worked for several years in radiation oncology when it became increasingly clear to me that there were many things that my patients needed which I did not know how to help them with, and palliative care was one of them. And it was at the suggestion of Dr. Robert Twycross that I went to Calicut in 1998. Dr. Rajgopal had started that unit when he was professor of anesthesia. And after by that time, about nearly a decade in oncology, I still learned some very, very basic things, which I still think form the pillars of not only palliative care, but even medicine. The three things that I specifically remember were simple things. One was to listen to the patient without too many interruptions. The second was to draw a family tree and understand the person who had the cancer. And the third was to opioids. So my talk today is very simple. It's about practically prescribing from my experience in a tertiary cancer center. I'll be looking at the balance between cost, accessibility, and acceptability, and trying to illustrate this through common scenarios. Over the course of the session, we will have a few polls. The idea of the polls is that if we know it, then we feel happy we've got it correct. If we are a little bit confused, then actually making a mistake, it's an anonymous poll, helps us remember much better. And these are things which can be translated into your practice the very next week. So it's a good refresher, and I hope you will participate in the anonymous polls. So let me also say at the outset that my talk is not a review of current evidence or clinical pharmacology. I'm not going to be talking about the newest drugs, nor, for want of time, am I touching on the big element of psychosocial distress, which is a major contributor to pain. Let's take this patient, Mr. S, who has a post-RT carcinoma base of tongue with multiple neck nodes. He has a nociceptive pain on the right side of the face and neck, and the pain score is 5. So, what is wrong with this step 2 prescription? It is a step 2 because the pain score is 5, so it's a moderate pain. And we have tablet tramadol given round the clock, tablet paracetamol given round the clock. So what are the options? Is the opioid incorrectly prescribed? Is it that we have not prescribed an NSAID, or is it some other error? So could we just launch that poll, and could you just anonymously choose one?
So all can see a question on your screen now. Just click on to most appropriate which you think.
Right, I think everyone has answered, and the most popular answer is that an NSAID has not been prescribed. Can everyone see the answers as well? So 5 out of 9 have said that an NSAID has not been prescribed. That is an understandable answer because we know that in the WHO ladder, a non-opioid is an important part of the pain prescription. But actually, that's not the right answer in this case because we do have a non-opioid, which is paracetamol. The right answer is another principle of the WHO guidelines: to anticipate and treat side effects, and to prescribe analgesics for breakthrough. Let's look for a minute at the second one. As you would have in pain management, in cancer pain management, we are titrating our dose of opioid or analgesics to the severity of pain. And we can think of this titration a little bit like when we go to the market and try to buy 1 kilogram of apples, maybe. You guesstimate and put a certain amount, and then you add a little bit to balance it, because often our first guess may not be right. We don't get it exactly right, and that titration happens through the PRNs. The second and even more important reason is that the patient suffers when the pain is not controlled. And one of the patients I cannot forget from very early in my career when I was a house officer was a man who had peripheral vascular disease, Berger's disease, had severe pain. He also had a non-healing ulcer, and I used to do his dressings every morning as the junior doctor. So one morning when I was doing the dressings, I noticed that some extra Proxavon wrappers were open. So that you take extra tablets, more than the 3 you have been prescribed. And he said, बेटी क्या करूं, जब दर्द ज़्यादा हो जाता है तो मैं और कुछ नहीं कर सकता. So I very self-righteously scolded him a little bit and said, you should only take what is prescribed. These drugs are dangerous. And he nodded his head. That night I was called to the ward for some other acute emergency, and as I was leaving, I happened to see this man. It was some 2-3 a.m. in the morning. The rest of the ward was asleep. He was sitting awake, and with one hand he was holding that painful leg, and with the other hand he was holding his mouth shut, trying not to scream and disturb his neighbors. So when a patient does not have an access to a safe SOS medication, these things can happen. And we know relatives are even more strict about imposing the regulations. So the next morning, I tried to advocate for this patient by telling my consultant, and the consultant's response was, well, there are no more procedures to be done, and to discharge the patient. So if I were to prescribe this correctly, I have my opioid, but I need to tell the patient what is the safe maximum dose of that opioid. While we do want to give PRNs, we also don't want to, give PRNs inappropriately, the safe maximum dose of the paracetamol for a middle-aged man in good shape, and the adverse effects which you have been taught about. Nausea and vomiting, which is generally only for the first few days. In fact, when I started after my training in the UK, I did not give antiemetics regularly. I just kept it SOS. Then I had a good number of my Indian patients coming back with vomiting and saying that I'm allergic to this tablet you gave me, I don't want to take it again. So then I thought it is just better that I don't lose their trust and give them this antiemetic for the first few days. And a laxative, because as you know, we cannot prescribe opioids without access to a laxative. And the laxative we use is not a bulk laxative, but a stimulant laxative. So that would be a more complete step 2 prescription. Let's go on to the next slide. And now our same patient, a month later, he's taking the tramadol. He's now taking the paracetamol to the maximum dose. His domperidone has come down because nausea was an early symptom, but his pain is still uncontrolled. So what would you do now? Okay, so can we have the next poll? Shall we switch to oral morphine 10 mg Q4H and SOS? Add oral morphine 5 mg Q4H and SOS? Switch to oral morphine 5 mg Q4H and SOS.
Raju, is the poll up?
Yes,
Yes, sir, it is.
Okay.
So a tie here with half saying switch to 10 mg Q4H and half saying switch to 5 mg Q4H and SOS. So let's go on to the slide there. Can everyone see the results? Remember, I used the analogy of weighing a kilo of apples. So when the pain is uncontrolled and we are titrating up, we definitely should not be giving less than the current opioid equivalent. Okay, so how much is Mr. S taking? When we add the regulars and the PRNs, he's taking 400 milligrams a day, the maximum that he can take. So it doesn't make sense to continue with the tramadol. That is roughly equivalent to 40 milligrams of morphine. And since we give the morphine 4 hourly, the equivalent dose of oral morphine is 6.6 mg Q4H. Practical dosage to advise anybody should be round off higher or lower. Two things: is the pain well controlled? No, it isn't. So it doesn't make sense to go lower. Is the patient otherwise metabolically okay? As far as we know he is. So when we are shifting from oral tramadol to oral morphine, i.e. if a patient is already on weak opioids, then a ballpark starting figure would be tab morphine IR 10 mg Q4H and SOS. We just rounded off a little bit higher. But if it was a patient who was not on a weak opioid and whose renal function was otherwise normal, then our second answer of 5 mg IR Q4H and SOS would be a better starting dose. Okay, any questions about that? Right. So now we have put Mr. S on morphine and he's continuing the non-opioid with the paracetamol. And a week later, he reports uncontrolled pain, disturbing sleep. So what shall we do now? So that's our third poll. Shall we increase the oral morphine? Shall we now add an NSAID? Or shall we check what else is happening? Yes, great. The majority, 7 out of 9, have said check what else is happening, which is a good principle generally, not only in palliative care, but also in clinical medicine. So when we check what else is happening, we realize that compliance and there might be various other contributors to pain. Like I said, I'm not getting into the huge issue of psychosocial, just the very basic issue of is Mr. S taking the drugs? Turns out he's taking the morphine 3 times a day. In between, he forgets. He's not taking the paracetamol because it's too big. And, when you ask him about this, he says 16 tablets a day. I don't even feel hungry. More tablets than food. Anyway, what's the point? The disease is not curable. And there's a whole iceberg in that last response. But focusing on just drug management, what can we do about the 16 tablets a day? Okay. Even if we tell him you have to take those 16 tablets a day, it's unlikely that he's going to. So what shall we do pharmacologically besides psychosocially? Shall we change to a transdermal patch so that he doesn't have to take so many tablets? Shall we replace paracetamol with an NSAID? Or shall we make some changes to morphine and paracetamol? Right. So here we have the largest number saying that we change to a transdermal patch. Let's look at it carefully. Okay? And now most of my questions are not with black and white answers because the idea was to generate discussion. When we are practicing therapeutics, whether it is chemotherapy or pain management, we follow some basic cardinal principles. For example, if you were considering doxorubicin for a patient, what is the estimated survival? Is it days, weeks, or months? What are the costs over the estimated survival? What are the toxicities over the estimated survival? And what coexistent problems are present? A different answer to any one of these could change the choice you make. So Mr. S has an estimated survival of several months. We know that most patients with head and neck cancer don't die very quickly. If I change his oral morphine to a transdermal patch, immediately I am increasing his monthly expense by rupees 4,000, which is about 80 liters of milk. 3 liters of milk a day could have fed him and his children. And remember, this is only one of the many healthcare related expenses he's having. It's just one of the drugs that he's taking. And healthcare is again only one element of the family budget. I think for most of us, 4,000 rupees, even as doctors, is a significant amount. So at that point, if I have an alternative, I would not want to immediately change to a patch. Replace paracetamol with an NSAID, not so many tablets, not so big tablets. About 20 years ago, a lot of my patients got NSAIDs. They're good drugs in short periods, but all NSAIDs, whether they are COX-1, COX-2, they all cause renal damage with long-term use. And now it is not something I use for a long time, except for very specific indications. Okay. So how else can I reduce the number of tablets? So sticking with the morphine, I can change the immediate release morphine to sustained release morphine. So instead of a day, he needs to take only twice a day. And paracetamol, if he were taking it, was a good thing. But since he is not, and I have had several times patients come back with a box full of paracetamol, which they are not taking. Can I change it to that third element of the ladder, the plus minus adjuvant? So what adjuvant can I use that will cover the symptom cluster? It doesn't make sense in somebody who's already struggling with too many tablets to add 3-4 different adjuvants for 3-4 different symptoms. So a little bit of a fun break. Let's forget Mr. S and remember ourselves. So at some point, when you had a respiratory infection or something, when you were prescribed cap ampicillin 500 mg QID for a week, how many of you took 4 times a day, every day for a week? How many took it 3 times a day? And how many took it 4 times a day for the first 3 days and then much less frequently later because you forgot and you felt better? So can we just have this poll as well? Wow, this was the quickest poll with the most unanimous answer. And it always makes me feel better because I'm absent-minded by nature, but at least in this matter, I have company. It is difficult to remember to take things 4 times a day, and 6 times a day is even more difficult, except that the pain reminds you. So really, if we want people to comply, we have to make things a little more user-friendly. Right. So anyway, I have switched him to tab morphine SR 30 mg twice a day, because remember he was taking 10 Q4H 60 and twice a day that becomes 30. I have kept my drugs for side effects, but the prescription is still not complete. So let's look at the next poll. What is the mistake in that prescription? Is it the wrong dose of SR morphine? Is it that there is no immediate release morphine? Or is it the wrong frequency of SR morphine? Let's have the next poll. I think we need a few more answers. Just take a guess. Okay, so it's fairly close. The commonest answer is no immediate release morphine, which is the correct answer. But let's just look at a little bit at the other 2 responses. The dose we are just converting to an equal dose. So he was getting 10 Q4H, 10 into 660. And the most commonly available sustained release tablet in twice daily, Q12H. So 60 divided by 2 is 30. So the frequency of Q12H or BD is correct and the dose is correct. But we go back to the problem we had with our first patient, our first poll, where, remember, we send the patient away without giving anything for breakthrough pain. So when Mr. S gets his pain, if he just takes a dose of SR morphine, it's not going to relieve his pain immediately. He still needs that IR morphine for breakthrough pain. So a correct prescription would look like tab morphine SR 30 mg BD, and for breakthrough pain, not 30 mg, but the Q4H dose, tab morphine IR 10 mg SOS. So what can we use instead of paracetamol? What are his symptoms? In that one sentence, he's told you he's not hungry, he's not sleeping. Because it's a carcinoma base of tongue, many of you would have seen that, they'll be pulling their ear, that glossopharyngeal. And he's saying, what's the point? Anyway, I'm not going to be cured. We see some grief, we see some hopelessness. What group of drugs could we use for this symptom cluster? Just a recap of the principles we mentioned. What is the estimated survival? Now it's in days to weeks. What are the costs over the estimated survival? What are the toxicities over the estimated survival? And what can help but not worsen coexistent problems? Okay. So we've got two antidepressants here. One is amitriptyline, the other is mirtazapine, and we have one anticonvulsant. We know that antidepressants and anticonvulsants are both adjuvants for neuropathic pain. When I look at the cost, the amitriptyline is really cheap, 75 rupees a month. The mirtazapine is a little more expensive, 200 rupees a month, but to most middle class people. And the pregabalin is anywhere between 1,000 to 3,000 rupees a month. When I look at the 75 versus the 200, the amitriptyline will cause a dry mouth. Post radiotherapy, he already has a dry mouth. It can cause urinary retention. Constipation, elderly man, we don't want that. It can cause postural hypertension. It can cause constipation. The mirtazapine can cause some weight gain, which in his context, his family and he might be quite happy about because he's actually losing weight. We do not have as much evidence for cancer-related neuropathic pain, but we have some evidence in fibromyalgia, and systematic reviews are now beginning to show that, yes, this little drug probably has a role to play. Both the antidepressants improve sleep and improve mood. Mirtazapine has fewer drug interactions. It also reduces nausea. The side effect profile of pregabalin I don't like so much, even though we have a lot of pharmacology sponsored trials which give us good evidence. So mirtazapine choose, but like I said, our answers are not black and white. So then my prescription becomes tab morphine SR 30 mg twice daily, tab morphine IR 10 mg SOS, mirtazapine 7.5 mg HS. If he was frail and elderly, I would have started with 3.75 plus the 2 other drugs for side effects. So we have now significantly reduced the number of tablets. 2 months later, Mr. S cannot swallow. A nasogastric tube has been inserted and he has a prognosis of several weeks. So what shall we do now? Shall we powder that sustained release morphine, because his food and his tablets, everything has to go down that tube? Shall we change to immediate release morphine, or shall we now change to a transdermal patch? So can we have this poll? Okay, so the commonest answer is to powder the SR morphine, and only one person has said change to a transdermal patch. I'm glad that only one person wanted to change to a patch now. I don't think we need to go to the patch yet. At the same time, we really do not want to powder the SR morphine. The correct answer now is to change to IR morphine. If we powder the SR morphine, we are altering the sustained release action of it. And effectively, you will be giving 30 mg of immediate release in one go. And that is likely to be an overdose. Instead, we can change it to IR morphine. Remember, now it is a family member who's probably giving the medicines and the food. And they're not having 3 big meals a day. They're probably having, several small liquid feeds. And that IR morphine can go in with that. Also, it is possible that, especially if the creat is now beginning to climb, that we may even need some reduction in dose. But please remember, do not powder sustained release morphine. And the reason for the patch, for not using the patch, is mostly the financial reason that I mentioned earlier. Now, suppose for some reason either Mr. S did not have a nasogastric tube, or he was vomiting all the time and you needed a parenteral route. How would you convert 10 milligram oral morphine to injectable subcutaneous morphine? Shall we give 5 mg subcut morphine instead of 10 mg oral morphine, or 10 mg subcut morphine instead of 10 mg oral morphine? Let's have that poll. Okay. Yeah. So the vast majority have chosen the correct answer, and it's a very, very important question, this one. 10 mg oral morphine, the equivalent dose would be 5 mg of subcut morphine. And at higher doses, sometimes you might even give a little lower than the calculated conversion. If you give exactly the same dose, 10 mg to 10 mg, you would be overdosing the patient. It could even be dangerous. Now, before we go to this question, I just want to share a couple of other things. All of you have joined this course because at some level you feel the need to know more to help your patients. Some of you may have worries about how do you start, where do you start, do you know enough, what will somebody think? I had several of these fears when I first ventured into palliative care. I was quite young then. Even now, I have many fears, so it's not that age takes away all fears. But one phrase that helped me then, I first heard from Dr. Twycross. In Dr. Twycross' style, it's few words put in a very masterly manner. Start low, go slow, but do so. So when I was finishing my 3 weeks in Calicut for my first training, I had told myself that if I don't do something within the next week, I might keep hesitating and not begin. And when I spoke to Dr. Rajgopal, he echoed the same words. He said, remember what Robert says, start low, go slow, but do so. I wanted to share that with you. So, in fact, what I did when I returned to Vellore was to ask my HOD if I could just rearrange my patients so that the patients who had these or palliative needs were seen in one morning and the curable ones were moved to the other mornings. I wasn't reducing my patients, just rearranging them. And I had made a pro forma based on the Calicut pro forma, but tailored to our setting. Because when you have a pro forma, it helps you not miss important things. Simple things like what does the patient understand, who is there in the family, what is the financial status. And I needed a little place, so I dusted out one empty storeroom and got a register and printed out some pro formas. And I didn't have oral morphine at that time because we didn't have an RMI license. But beginning with what I had, I was able to learn a lot more from my patients and also able to see the need for getting that RMI license and continuing to learn more. So I hope all of you, wherever you are, will be able to take that first next step. Suppose Mr. S or somebody else is in the very terminal phase. He's been on morphine 10 mg Q4H and SOS. For some reason, we can't give injections at home. We are switching to a fentanyl patch. How do we do that? Okay. You would have already done that. It's just a recap. A simple way to remember is that if you multiply the hourly oral morphine dose in milligrams by 10, you will obtain the hourly fentanyl dose in micrograms. Fentanyl is 100 times more potent. So 10 mg Q4H of oral morphine is 10 by 4, 2.5 mg per hour of oral morphine. 2.5 into 10, we get the 10 by multiplying 1000 micrograms and dividing by 100 potency. That makes 25 microgram per hour. Another way as a cross-check is that, the most commonly available small tablet of morphine, the 10 mg tablet, is equal to our most commonly available small patch, the 25 microgram patch. Here, let's 4 hours. 10 mg Q4S is 10 into 6, 60 milligrams of oral morphine. 60 milligrams into 100 is into 10 is 600 micrograms of fentanyl over 24 hours. And if you're good with maths and can mentally divide 600 by 24, we come back to our 25 microgram patch per hour. Now, when we are putting the patient on the fentanyl patch, do we need to continue the morphine? Okay, so that's one more poll. We have two choices here. Yes, some more people have got the right answer correct. And the reason for that is we know that the fentanyl patch is not immediately going to reach steady state, it just has to build up. So we apply the patch and we ask the nurses to continue administering regular oral morphine 4 to 6 hourly for 12 hours, or the subcutaneous injection if that's what he's on. Then we stop the regular morphine and we still need that thing for PRN or SOS, even with somebody on a patch. So, like I said, after about 6 months of doing this little clinic of mine, I had the opportunity to work for over a year with Dr. Robert Twycross in Oxford. Now, Dr. Twycross is the person who did the first RCTs on morphine. He's the one who writes the palliative care formulary. His storehouse of knowledge is vast. But interestingly enough, when I worked with him, he never caught us out for not being able to report the latest evidence, for it with the receptors of the latest drugs. He never caught us out for those. The things which he stressed, one was, are we ensuring that the patient can understand what he has to take? Why are we not using the simplest and the most cost-effective medicine? Why do we want to jump into the latest fashion? As you know, sometimes the residents would like to because there's a nice new drug that's making the buzz. And then he'd say, 20 years ago, we didn't have this drug and we still managed to control symptoms. So, can you do something about side effects? Can you tweak something? And like we know in oncology, a cost-effective protocol that a patient will comply with and continue is better than a state-of-the-art regime that may be discontinued. Another thing I've learned over the years is that sometimes today's popular drug, after 10 years, you discover some very nasty side effects and then everybody feels a bit foolish about having used it. So those were the basic principles I wanted to share with you, and thank you for joining this course and thank you for participating in the polls.
Thank you, ma'am.
Yes, Dr. Ashok.
Thank you, ma'am, for that wonderful session. I think a lot of polls also helped our participants get a good idea about how we should prescribe these drugs and what are the common mistakes we make while we do this. So we finished well in time, so we have plenty of time for questions. So I'd like to invite any of you, if you have any questions, to please ask Dr. Reena, or you can put it in the chat box and we can answer it from there. If anyone would like to ask anything, please unmute yourself and ask your question.
How many of you already have oral morphine? Can anyone just put it in the chat box?
Or even you can unmute and speak. We have good amount of time with us now.
Ma'am, Dr. Vinayak, ma'am. I can't hear you, ma'am, actually. Ma'am, transdermal routes. I think there's a lot of takeaway for me, at least, to practice that using all oral drugs adequately. But one thing I want to understand is transdermal thing, which is how to rationalize use in your practice. Bular plus also as fentanyl.
Yes, thank you for stressing that point. Like I said, I mean, in my years in palliative care, the buprenorphine patch I tended to use mostly in patients with renal failure who needed a small dose of opioid. And since they were already survival was likely to be short. So if they were opioid naive, I would start with 5. If they were already on opioids, I would go with the 10 microgram patch. Otherwise, patches I used really only if the oral route or the subcutaneous route was not feasible. And when the duration for which I needed it was maybe not more than a couple of weeks. So if a patient who is, or the very rare patient in whom I just could not control vomiting with other medications. Now, one of the tips there is that, for example, if somebody is on oral morphine and having a fair bit of vomiting, if you make the antiemetic subcutaneous, if you teach the relatives how to give the antiemetic subcutaneously, that often controls the vomiting and they're able to tolerate the oral morphine. And that's much cheaper than switching to a patch long term.
Thank you, ma'am.
Yeah. Also, someone's unconscious, final days, they don't want an NG tube, family doesn't want to give subcutes, I might use a patch, but not very often. A few questions in the chat.
Ma'am, I think no one is asking, then I can ask a few more questions, ma'am.
Yeah.
In neuropathic pain, this is learning for me that I prefer to use pregabalin. Never thought of financial cost of it, so I'm going to use other 2 drugs more often. These are for as a practicing oncologist, 2 pains are very terrible for us to manage.
Yes.
One is the bone pain.
Yes.
Usually, mostly it comes down with zoldonic acid, but still the pains will persist longer. And second is neuropathic pain. We do is sometimes I use pregabalin or something. So you will take on both this intractable pains, which.
Yes. Now, actually, for bone pain, especially, if it is possible to give even a single fraction of radiotherapy or a short course of radiotherapy, that it will not act in a day or 2, but within a month, some relief you'll see in a week and good relief you'll see in a month. That would be by far the best thing to do. We actually did a randomized trial where what we did was for the first 2 days, saline and one group got zoledronic acid. Both had access to SOS pain medication. Then both groups got radiotherapy. And then we followed them up for a month. So the things we found was that the zoledronic acid didn't do very much more than an extra dose of painkiller would have done. The radiotherapy made a significant difference, but we saw only, like the pain score, if it was 8, by the end of RT, it would have come down to 4 or 5. But by the end of a month, it was 2 or 3. in both the groups, whether they got saline or whether they got the bisphosphonate. So yeah, so one thing is radiotherapy. The second, this may be a situation where you might want to use an NSAID for some time. And if there is a compression element to the pain, like especially cord compression, spine meds, then you might want to think of using dexamethasone along with radiotherapy. Similar principles, neuropathic pain, if it's possible to give some RT, it is good. Often you may need a short course of steroids if there's a nerve compression, like if you've got, breast cancer with big supraclavicular nodes chewing up the brachial plexus, or a Pancoast tumor chewing up the brachial plexus. Radiotherapy and steroids are important, but you usually will need an adjuvant. And for the reasons I mentioned, my go-to adjuvant is now mirtazapine. Many people use amitriptyline, but I just, dry mouth, postural hypertension, constipation, I don't really want. And for complex neuropathic pains, if you can give some radiotherapy, that helps. Now, this is my limited armamentarium with drugs and RT. I think Rajgopal sir would have much more to add. Sir?
Reena, thank you. The way the symbol cannot be simpler, can you? I mean, it all profound knowledge delivered in such a simple way. It was a treat to listen to you.
Thank you.
Reena, in the last 2 to 3 years, one thing that has revolutionized our pain management is methadone.
Yes.
Doctors, in step 3 of the ladder, really we have only 3 medicines in the country. Reena has worked in the UK. She must have had about more than half a dozen in the step 3. Whereas we have nothing else. We have morphine not injectable, but otherwise morphine, fentanyl, and methadone. Methadone is new. It came into the Indian market only 4 years back. Fentanyl has a huge problem is that the children of the family will starve. The cost, in addition to all other disadvantages. For patients who do not tolerate morphine well, which could be up to 1/4 of patients, reasons may be many, including the neurotoxicity with morphine, myoclonus, delirium, etc. Methadone seems to be a good alternative. Methadone is inexpensive. But the catch, there's always a catch, isn't it? The catch is that it is not as simple to use as morphine. Methadone, see, with morphine, if I've started 10 milligrams for early, day after tomorrow, I can easily decide the blood level has plateaued by day after tomorrow in about 36 to 48 hours. It has plateaued. I can increase the dose. Whereas here we'll have to wait for 5 days at least. And the second problem is it is significant cardiac toxicity. In the sense, it prolongs the QT interval, and therefore, if you just start a large dose and quickly try to build it, it could be dangerous. So why am I still saying it? For those of you who are already well versed with morphine, it may be a good idea to procure methadone and start using it rather carefully. The Indian Journal of Palliative Care 2020, I think, had a special supplement. If you just Google for Indian Journal of Palliative Care special supplement methadone, it will come. It has one issue dedicated to methadone. That will be a good armamentarium in our arsenal. Reena, one question. Maybe there are more questions about methadone. I'll try to answer them. In addition to being good for bone pain, would radiation also prevent or reduce the chance of pathological fractures?
Yes, sir. It probably would. And other problems which can be there due to pressure effects. So but the important thing is to tell your radiation oncologist not to go overboard with IMRT or very long courses. As we know, in bone pain, a single fraction is often enough.
There is, I can't remember whether it is American Cancer Society or some other body. It's very clear guideline saying that in metastatic cancer, palliative radiation should be a single fraction with a second fraction offered in case the pain relief is inadequate. And very clear guideline not to give 5 to 10 courses of fractions. And very recently, Dr. Christopher Booth, an oncologist who many of you know from Queen's University in Belfast, published a paper. This was in 2021, where he talks about the value of time for a person with limited lifespan left. For every young doctor here, your lifespan is okay, potentially so much, though there is an uncertainty. And 5 days do not matter that much to you. Whereas for the person with only 2 months to live, every day is so precious. And that cannot be spent on hospital corridors and radiation units. And he keeps highlighting the point, reduce the time spent in hospitals, allow the people to live their life if the time is limited. So for more than one reason, one fraction. If there's when necessary, a second one, but not more than that.
That's very, very true. And in fact, for some of them, just the traveling to hospital multiple times can precipitate that pathologic fracture. It's not always easy to come.
And Reena brought up that point about the cost several times, cost of treatment. Time is up. But I still remember the face of a woman, a 42-year-old woman who was having advanced cancer. She was having pain, severe pain and bleeding. And I asked her, what's the biggest problem? She just burst out crying. And when the sobs had subsided, she said, my daughter has not eaten since yesterday. All their money was spent on medicines, including multivitamin and mineral preparations. The impact of financial toxicity in our country is usually unrecognized. Sorry, I went overboard with my comments. Time is up.
No, sir, thank you so much. So thank you all for